I'm Dan Hamilton with the American College of Surgeons Division of Integrated Communications. Today we're hearing from Dr. Michael Sarap. Dr. Sarap is chair of the American College of Surgeons Advisory Council for Rural Surgery, and he's a surgeon in Cambridge, Ohio. He's going to be sharing his experience as a rural surgeon during the COVID-19 pandemic. Dr. Sarap, thank you for taking the time to share your thoughts.
Yeah, thanks for having me.
Can you begin just by telling us what your experience has been so far with the COVID-19 pandemic?
Yeah, really, it's summed up in about two words: is preparation and anticipation. We're quite a rural county. We do have two interstates and two state highways intersect right in our town. We were thinking that that would really not do very well with us in terms of surge, but we've had 3 patients in the county so far that have been positive, and they're all at home. Supposedly, the website says that our peak in Ohio was yesterday, and so we may or may not have a big surge. I think part of it has been that the Ohio governor and the Department of Health official in Ohio really were at the cutting edge of these maneuvers that would decrease the surge. And so it's very unclear to us, even with all this preparation, how many patients we're going to get.
And being in a rural community, can you talk a little bit about the challenges and strengths specific to your community in dealing with COVID-19?
Yeah, the challenge has been our workforce. We've quit doing all of our elective surgery and elective endoscopy and a lot of elective radiology procedures, and so the hospital is empty in preparation for a surge. And so we have redeployed much of the people from the operating room and the endoscopy unit. They're working the outside screening tent, and they're doing temperatures at the front door entrances. If they've had an ICU experience, they've been moved back to the ICU to cover off shifts. But trying to figure out what to do with all these people with an empty hospital is a real challenge. The biggest challenge, perhaps, even if we don't have a surge, is going to be economic. I have a 3-person private practice in surgery, and elective surgery is the mainstay of our income, as it is for our hospital, a significant part of the budget. And we have not done that since March 25th. Ohio was very early on saying that we need to limit to cases that had to do with saving lives, saving limbs, or venting advancement of disease or metastasis. So rural hospitals are already behind the 8 ball, and ours is no different than that. An article came out today that 1/4 of the rural hospitals in this country may close because of COVID. My advisory council has been looking at this problem for many years, but we're talking about over 350 hospitals in 40 states are really on the cusp of bankruptcy, and COVID may push them over. So that's a bothersome thing. We're getting ready for something that might not happen in our small institutions. On the other hand, the fact that we are rural might be a strength, and that we might miss this big surge that's happening in the urban and metropolitan areas. Even Columbus, Ohio, our big referral center, is not getting the surge that they expected. The other strength that we have is we're used to working together. So we have a very physician-minded administration. And so at the very beginning, we huddled with administration and with input to properly plan for this, and it's really helped. Another strength we have that some hospitals do and some don't is that we have an affiliation with a large healthcare system in Columbus, Ohio, called Ohio Health. We have a loose affiliation. We're a private hospital. We still run our own board, but we have a management agreement with Ohio Health. And so what that has done is we have not had to reinvent the wheel. We've used a significant amount of their policies and procedures and the plans that they had in action quite a long time ago in preparation for this. Another added bonus is that they were one of the ones that were in cooperation with Battelle Labs in Columbus, developed a way to reprocess these N95 masks. And so in our affiliation with Ohio Health, we can send all of our N95s after they've been used and get them back. And my understanding is they're doing 10 or 20,000 a day, which is pretty amazing. Lastly, I guess another strength is that from our association with being a level 3 trauma center a number of years back, we're part of what we call COTS, which is Central Ohio Trauma System. They are actually the people that are planning for the surge in this region of Central Ohio. And so we're part of that surge plan. And so our hope was all along that the sickest of the sick, we could find a bed, intensive care unit bed in Columbus at one of the 3 hospital systems. They actually had 1,000 beds ready to set up at the Columbus Convention Center. Each hospital, each of the big 3 hospitals in Columbus, Ohio Health, Ohio State, and Mount Carmel would have a mini hospital set up at that convention center, which would offload the minimally sick COVID patients to leave space for the sick ones. Ohio Health just mentioned yesterday that just within their own system, they've added 600 more critical care beds to their surge capacity alone. So our association with that regional trauma system has paid off for us really well. And then the other strength is rural communities. We're on our own most of the time. We are resilient, we depend on each other. And the community support that we have seen with our folks in our community, every single day we get dozens of donuts dropped off at the front tent. Just today, every floor had a huge pizza delivered by one of the pizza companies in town. So the support for healthcare workers that have had their schedules disrupted, that have this fear of taking this back to their families, the community has really supported us tremendously.
That's great. And it sounds like you've reacted well as a community and as a medical center to the pandemic. So is there any more specifics you can share about the ramp up in your hospital to treat the COVID-19 surge?
Yeah, we started this very early, as did the state of Ohio. And as soon as the governor said this is going to be a problem, we started an incident command center, and that's per Ohio state law. And so there are representatives in one single conference room all day, every day, from nursing, the medical staff office, human resources, infectious disease. They're constantly on the phone with the Ohio Department of Health. The governor and the health director have a daily television conference, very much like the president does, and they've actually got national attention for their forward thinking. And so we were ready. We locked down the hospital very quickly. Nobody can get in or out unless they have their temperature taken. There are no visitors that can come with the patients unless, number one, they're having a baby, and if they're at the end of life. We've been trying to get the families in. We have been doing patient visits by telemedicine, trying to help with that. We have a tent outside. Nobody gets in the hospital until we've screened them, done their temperature. And so the ramp up included stopping all these elective procedures on March 25th. And we do all the general surgery and vascular and endocrine and all the endoscopy for several counties. And so that would be already several hundred procedures that we have canceled. And we have reams and reams of lists of patients that we have to call back in when this ramps back up. We set up an entire floor as a COVID unit. We changed airflow with our maintenance folks, and it wasn't very easy to do that. They had the jury-rigged a lot of rooms to have one dedicated operating room for that one COVID patient or suspected COVID patient. And we have changed the airflow in our PACU as well, our recovery room. We have intubation hoods that we can take to the floor that will prevent aerosolization of the virus. For our anesthesia folks, actually done a video where we go up to the floor. The people that are in their PPEs will move the patient from the isolation bed to the recovery room, is where we're intubating patients because of the negative flow, and then into the specialized operating room, and then back, and just every step by step, so that the rest of the staff, if they're in an off shift, can understand how exactly we're going to do this and prevent contamination to them. We've also ramped up and done a walkthrough of a potential tracheostomy, although we hope we don't have to do that in a positive patient. We've taken stock of all of our PPEs and our ventilators, and more importantly, every day it seems like a new challenge, is that our anesthesia folks have been very much on board and have alerted us that the drugs that they will need to intubate and keep somebody on a ventilator are in short supply. So it's another very good reason that we stopped doing elective procedures, that we wouldn't use those drugs up. Everything is on back order across the country. And so that even if you have enough ventilators and ICU nurses, If you don't have the appropriate medication to keep people on a ventilator, that's a major barrier. In town, we have also ramped up telemedicine. The internal medicine family docs have done that. Our practice of surgery is kind of difficult to see somebody on a video and actually check their incision or drain an abscess or take stitches out. And so we haven't ramped that up tremendously at this point in time, but the rest of the folks in town have done a good job of getting that going. One of the barriers in Appalachia where we practice is a lot of folks are very elderly, not tech-wise, and broadband width is a problem in rural America. Many of them don't have the internet services to be able to do that.
And yeah, with the COVID-19 situation changing so rapidly, how are you obtaining new information and adapting to changing needs as the situation progresses?
Yeah, I think that we have to put a shout out to the leadership of the American College of Surgeons. They were really on this very early. They put out this COVID bulletin. I think we're on issue 6. And we look forward to that twice a week. We read every item, and I have been forwarding that to my administrator and to my chief of anesthesia. And truly, we have changed what we do on a daily basis, depending on what the college pushes out. They're checking on all the most recent research, they're verifying facts, and if it's in that bulletin, we know that that's good, verifiable science. And so one day, the people on the floor aren't wearing masks, but the very next day now, everybody has a mask and eyewear that they have to wear for the whole shift if they are directly involved in patient care. It's been very fluid, very, very fluid situation. And so we've looked to the bulletin from the college. And the other thing is the ACS communities, the online communities have been an incredible source of knowledge. Just figuring out how to make this plexiglass intubation box that came out very quickly, the dimensions of that, a video about doing tracheostomies, how to protect yourself with a deal where you put an external retractor and a drape over that. So the communities and the college, obviously the CDC comes out with things and the AMA have done things, but quite frankly, the college has done a tremendous job, and we've tried to keep up. And I think that everybody else on my team, administrators and anesthesia and the other folks are paying attention to this as well. So the college have to shout out to them. As an advisory board chair, I've been involved in some of the information being shoved that way. I did a report to the regents about rural surgery and the effects, and so we talked to rural surgeons across the country, and a written report for the regents of the college in terms of how that affects us.
And finally, do you have any specific lessons that you've learned during the pandemic that you would like to share with other surgeons?
Yeah, I think the number one lesson is that I think that hospitals that have physician involvement and teamwork between administration and physicians are much better prepared for this. Even if we don't have much to prepare for, we may not think, hopefully. The hospitals that are administratively run and just dictums are thrown down to the physicians and the nurses generally are not going to fare as well with their preparation. I think we learned that pretty early. And I've learned that through the communities and speaking to surgeons, rural surgeons, general surgeons across the country. The other lesson I think that I'd like to shoot out there is, particularly for private practice surgeons, is that there are dates being thrown out in Alaska and some other states are talking June 15th as the date that we may be able to go back to do elective surgery. That is untenable from a financial standpoint for a private practitioner, and it's untenable for rural hospitals. The college has been amazing in terms of our advocacy efforts and getting what we need into those CARES acts on the financial support. So, I mean, the lessons I'd like to push out to other private practitioners is there is financial support in the terms of a paycheck protection plan that you can get money ahead that is in the form of a loan, but it may not need to be paid back. There's a Medicare advanced and accelerated payment program that the Medicare will give you 3 months of your Medicare receipts ahead of time that you can pay back over a period of 7 months. They might, and then there are small business loans as well that you can look into, but these programs are being highlighted by the college from an economic standpoint for survival. Some of these are going to benefit rural hospitals as well. I would sincerely hope that the fourth CARES Act, when it comes out, We'll additionally give direct financial support to physicians that are on the front line. We're not particularly on the front line caring for COVID patients, but we're delaying everything else we do to make a living to prepare for our community. And in the process, having a high risk for having a bankrupt practice. And so we're hopeful that our advocacy folks in DC will continue to push for help for rural hospitals and rural physicians in going forward.
Thank you, Dr. Sarap, and we appreciate your work and your willingness to share your experiences with us and with surgeons around the U.S. and around the world.
Yeah, I guess I'd like to make one more point is that if you look at the demographics of the rural workforce in terms of rural surgeons, there's a significant number of us that are over 60 years old and older that are male. And it's interesting, that's the same demographic that has increasing complications if they get COVID. Many academic centers are sending surgeons that are 60, 65, 70 years old home, and they're not allowed to work till this is over. In a rural environment, there may be one surgeon in a community, and that surgeon may be the only one with critical care experience, or he may be caring for an entire hospital, and the ramifications if that individual gets ill, that means the whole hospital loses their provider. And if we lose some rural practitioners through this disease, it could affect rural access to care for 10, 20 years. If you lose hospitals because of COVID, you're going to lose access to surgical and other care, perhaps for a decade or two. These hospitals will never back open again. You're never going to be able to recruit a surgeon. And so there's a palpable fear of surgeons, particularly my age, that going to work for the first time, I've been in practice 33 years, I've never really been afraid of hepatitis or HIV. If you're careful in the operating room, you take protection. In this case, it's so insidious that everybody that you see is a potential carrier, even if they're not symptomatic. And so we're not going to stay home. We're going to continue to care for our communities. That's what we do in rural America. But I think for the first time, many of us are fearful about what the ramifications are about going to work. So I really appreciate the ability to talk about what we're doing in rural America. And we're out here taking care of our communities.
Thank you. And I know these are incredibly important points. And I know surgeons all over the world are going to appreciate hearing what your experience has been so far.
Thank you very much. Stay safe.
You too.